Okay, hi everyone. Happy Thursday. Thank y'all for being here. We know there's a lot of places you could be on a Thursday evening, and we're so glad that you're spending it here with Carolina Forward. My name is Hannah. I'm a health policy professional, receiving my master's from the University of North Carolina and specializing in Medicaid here in the state. After I graduated, I went on to work for the Department of Health and Human Services as a research fellow specializing in Medicaid tailored plans. From there, I then went on to lead the prenatal mental health and Medicaid portfolio at a statewide nonprofit. And that brings us to today. I'm the director and founder of a program called Influence NC. In partnership with Carolina Forward and the Fine Glass Fund, Influence NC was created to serve as an online community that educates on North Carolina politics, provides resources for you to better communicate to your communities. We offer specialized social media training for elected officials to better communicate with their constituents, and we are officially launching less than a week from today on October 1st. Please make sure to follow us on all platforms at Influence NC. I want to thank everyone that submitted questions ahead of time. We did our best to incorporate as many as possible. There are some light snacks, so please make sure throughout this program that you go and grab some food, some drinks, and come back in. We are thrilled to have three incredible leaders and advocates for the state of North Carolina here with us today. We first have former North Carolina Secretary of Health, Kody Kinsley. Kody Kinsley served as North Carolina's 18th Secretary of Health and Human Services under Governor Roy Cooper, unanimously confirmed by the North Carolina Senate. Throughout his tenure, he focused on making health more affordable and accessible for all North Carolinians, including those in underserved and overlooked rural areas. Kinsley played a pivotal role in expanding Medicaid through bipartisan collaboration with the General Assembly, resulting in over 600,000 North Carolinians gaining coverage in the first year, which is twice in the expected pace. He secured one of the largest behavioral health investments in the state's history, $835 million, and a major policy reform to expand access to mental health and substance use services. He implemented North Carolina's groundbreaking Healthy Opportunities pilot, the nation's first large-scale experiment proving that paying for non-medical health needs like food and housing improves and lowers cost. Next, we have North Carolina House of Representatives member Vernetta Alston. Representative Vernetta Alston has served District 29 in North Carolina's House of Representatives since 2020. A Durham native, she earned her BA in Political Science from North Carolina State University and her JD from the University of North Carolina Chapel Hill School of Law. She's also a civil rights attorney at Tin Fulton, Walker & Owen. In the House, Representative Alston has been a strong advocate for LGBTQ+ equality, well-funded schools, and a thriving economy, as well as healthier and safer communities. She has emerged as a leader on housing policy in the state legislature and serves on Governor Stein's Council on Workforce and Apprenticeships, advancing opportunities for working families across the state. Now a member of the Democratic leadership in the North Carolina House, Representative Alston is committed to expanding Democratic power and ensuring the legislature makes investments and improvements that improve the lives of all North Carolinians. Last and certainly not least, we have Captain Scott Peoples. Scott received his commission as an Army officer through the ROTC program at UCLA in 2009. He then served as a quartermaster officer in the 82nd Airborne Division until 2014. During his time in service, his unit was assigned to the Global Response Force mission, and then Scott honorably left the Army with the rank of captain. After leaving the military, Scott served as a veteran transition specialist for Hire Heroes USA. During his role, Scott helped veterans of all ranks transitioning from the military to find meaningful employment. Scott became a project manager for one of the world's leading data and analytics companies, SAS. Now he and his wife own and manage a wedding venue together in Raleigh, North Carolina. They are proud parents of two wonderful children. Scott strongly believes that democracy is not a specter sport and has been involved with Veterans for Responsible Leadership since 2020. He's had numerous op-eds published and appeared on various local news outlets across North Carolina, advocating for free and fair elections. He now serves as a chairman of the board for Veterans for Responsible Leadership, and he advocates for veterans' health care and benefits, especially throughout the PACT Act. I know that was a lot. We have some lovely people up here. Before we get into our questions, I also wanted to take a moment to acknowledge the significance of this week. This marks 1 year since Hurricane Helene. Hurricane Helene made landfall, devastating the western part of North Carolina. A year later, many communities are still grappling with the expensive physical and emotional impacts of the storm, which makes it crucial for us to reflect on the far reaching effects that Hurricane Helene has had on our state. A year later, we understand that a significant number of residents depend heavily on essential programs like Medicaid and the VA system for their basic healthcare needs. This reliance becomes even more pronounced during natural disasters, when access to medical services can be severely disrupted. The importance of these programs cannot be overstated, and as we provide critical support not only in times of crisis, but as communities work together toward recovery and rebuilding. We have a lot of questions, so I'm really excited to get into it. The first one we're going to talk about is timeline. I feel like in the news we see on a state and national level, we know that cuts are happening, but what that actually looks like in the day-to-day, I think is unclear to most. So I wanted to kick this over to Secretary Kinsley to see if you could give us a little bit more insight on the timeline for anticipated Medicaid cuts and what that impact will be on North Carolina.
Sure thing. Well, it's such a pleasure to be here with everyone and have this conversation tonight. So let's back up. The bill that now is law, H.R. 1, that was referred to as the one big beautiful thing, came into law. And by and large, I just want to be clear, this is a healthcare bill. Since the Affordable Care Act 15 years ago, it's more changes to health policy in this country than we have seen. And it will take $1 trillion out of healthcare over the decade. And that is going to hit people in a number of ways. First and foremost, the thing that is most on the horizon, or the closest on the horizon, is changes to the way that Affordable Care Act rates are set. So for anyone like myself, I actually get my health insurance through healthcare.gov right now. If you get your health insurance through healthcare.gov, you're going to see your rates go up starting in January. Those rates have already been set. And the key driver of that is because there was a premium tax credit that 96% of people in North Carolina who had a plan through healthcare.gov will lose. Congress in H.R. 1 decided not to extend those tax credits beyond December. And so 1 million people get health insurance through healthcare.gov. We expect the prices to go up so much that about a quarter of them will just drop insurance entirely. To give an example of that, an individual that is 60 years old, so my parents, they didn't have insurance before they qualified for Medicare. They were buying their health insurance through healthcare.gov 12 years ago. They were 60 at the time, so if it was today, 60 years old, making roughly $80,000 a year, they'd see their health insurance prices go up by $7,000 a year per person. And if you're that person making $80,000 a year, to see more than 10% of your income go up going to health insurance, you probably can't afford it, which is why we anticipate many people are just going to drop insurance entirely. So roughly 1 million people getting insurance through healthcare.gov, about a quarter of them, 250,000, we expect to lose coverage starting in January. So that's a big concern that's going to be happening very soon. There's an active fight on this issue right now unfolding in D.C., tethered to the upcoming potential government shutdown. And so there's a chance that that could change, but that's what the law is at the present moment. The next thing that is on the horizon beyond that is changes to the way we do Medicaid. So Medicaid is an entitlement program. Roughly 3 million North Carolinians have access to this program based off their income. Through Medicaid expansion, we increased the income threshold so about 675,000 people could come onto it. For that expansion population, the law, starting next year, will require people to do two things differently. One, if they're on expansion, they will have to become requalified every 6 months. Right now, they have to do it once a year. They have to go in every 6 months, so just more churn. And the second thing that will be different is they'll have to prove that they're working every period of time or attempting to get a job. Now, what I like to think of this as is it's not actually work requirements, it's paperwork requirements. There's going to be a significant amount of effort into proving that. And think of it this way. Perhaps like me, you work in a job where you get a W-2. Send the money, send the form, you're done, check. But what if you work for Uber? Or what if you have a series of part-time jobs or a patchwork of things? Trying to get that paperwork together while you're navigating your life and your multiple part-time jobs and going to sit in an office for several hours can be really hard. And what we know, there's only been 2 states that have attempted to put work requirements in place. And I call those states struggle buses. because they spent millions and millions and millions and millions and millions of dollars implementing work requirements and really did not show much work for it. The last thing I'll kind of say on this point is like we're a big fan of thinking work and health go hand in hand. When I was secretary, we worked hard to make sure that work was a key component of supporting people with mental illness. We thought supportive employment programs help support people to be connected to community, to do well, to earn income, to support themselves, no question. By and large, the vast majority of people on Medicaid already are working. We know this through surveys and other things that we do. If they're not working, they're usually taking care of a caregiver, or they're a caregiver for someone who needs support. And so that's why it's just a lot of extra process for no good value. And it all leads to people coming off the program, and which is how they regain the $1 trillion. So we'll start to see that unfold more in the coming year. And again, there's still a lot of uncertainty exactly how it will roll out because there hasn't been a lot of clarity from the federal government about what they expect as far as how it'll be implemented.
Thank you so much. We're talking about timeline again, so I'm going to have this go over to you. The question is, what is the timeline for VA cuts? We know that we've seen a lot of that impact as well, with over 30,000 VA employees being fired. Do we have any more clarity around if more cuts are coming, and what does that timeline look like?
Yep, thank you. And once again, thanks for everyone for having me. Before answering that, I just wanted to kind of answer the general question of why is the VA so important, and why is it so important that it's fully funded or isn't funded as it can be. The wars in Iraq and Afghanistan were the first wars where it was a major conflict where there wasn't a draft, so it was an all-volunteer force. So, someone that is recruited into the military and is, raises their right hand. One of the things that, we're told once you sign on the dotted line that, we're going to take care of you after your service. There's two things that anyone who goes in the military, especially if they go into conflict, is hopefully promise that their family is going to be taken care of while they're overseas, and then when they get out, their medical care and their mental care will, be looked after. Veterans care should not just be a line item in a budget. I fully believe that how we take care of our veterans after returning from war says a lot about the moral fabric of a country. So, and that was one of the leading up, the tragedies of the war in Iraq and Afghanistan is we didn't prepare the VA for what was coming with tens of thousands, hundreds of thousands of injured soldiers coming back, mental health problems, traumatic brain injuries. So we are at a huge hole that we've been digging out of for decades. And one thing that, say a lot about the Biden-Harris administration, good or bad, but one thing they really put the most investment in veterans health care than any other administration has, at least in my lifetime, through what was passed called the PACT Act. What that was an act that was any service members that were exposed to toxic, burn pits, even going back to the Vietnam War, that were exposed to Agent Orange. They were allowed presumptive care, which meant that if you served in those conflicts and you had a certain type of cancer or respiratory illness, you were presumed that it was because of your military service, and that you could now get VA benefits for those illnesses. So that was signed in 2022, and within that, 1 million veterans were brought into the system very quickly, which is a great thing. They were offered this care that they should have been getting for decades. And with that, the Biden-Harris administration, hired tens of thousands of doctors, nurses, psychologists, social workers. But at the end of their administration after the election, we're still at shortages. They were digging out of a decade's hole, so it's not like when they left, the VA was fully staffed. So the tragedy of the DOGE cuts was we were already starting from a place where 1 million new veterans are at the VA currently. There's a little bit over 9 million veterans across the country use VA clinics, and so when we're already starting from a shortage, and then they come in the first few months, they cut about 6,000 in that first month, and it's not even just that they were cutting employees; it was the way they went about it. Doctors that just just got signed in the last year, just getting emails saying, thanks, but no thanks. So, anyone who's been to the VA knows it's a community. That's the importance of the VA is, not necessarily the the medical care is so much better than a private doctor, but it's specific towards veterans, and it's a community of veterans. A third of the people that work at the VA are veterans themselves, so you come in and you feel at home with the people that had that sense of service with you. So they came in, and the initial plan was to roll back the numbers that worked at the VA to 2019 levels, which meant they were planning to cut by coming up the end of this fiscal year here on October 1st. They're planning to cut about 80 to 90,000 people, employees from the VA. Luckily, due to really intense public pressure, a lot of different protests from nurses and doctors themselves at VA clinics, they realize this is, kind of bipartisan, not a popular way to go about it. So the number they came up with right now was 30,000 employees that have been cut from the VA, and that it's probably more about 30 to 40,000, because another downside is a lot of people are self-selecting, doctors and nurses to leave the VA, because you come in to work to the VA, you think it's about stability. You're coming in, you're as a anyone that's a doctor or nurse that comes into the VA, obviously they have a sense of service themselves. They could be making more money outside the private sector, but the stability of a government job is something that attracts them. So now when that stability is gone, the recruitment levels over the last 9 months have dipped. There have been more nurses that have left the VA than are coming in. There's been some analysis done that more doctors are rejecting offers that they're getting, where in past years they would have taken these jobs, but they're saying, I don't want to take something where I could be fired next year. So what that means for the veteran population and the general population is the quality of care is gonna start to dip. The Trump administration, I think, has a mindset of, over the long term, wanting to more privatize the VA. You've probably heard that in the news. Right now there's something called community care, which when it works at its best, it could be a good thing for the veterans, where we should be strengthening the VA. But then if you're someone in a rural location that has a super long drive, maybe you can go to your local doctor and it can be covered for the VA, or if there's an urgent care or emergency care. Kind of it seems to be the Trump administration's mindset that government health care is not quality health care, so let's just let these veterans go into the private sector like everybody else. But what that's going to do is dilute, if you got 9 million veterans going into the private sector, that's going to dilute the quality of care across the board as well. So so right now, to finalize your question, it's about 30,000 that have left, and they haven't put out their plan for the next fiscal year, but they have shown that they're willing to more fund the community care, so veterans can use the private doctors, and they're underfunding the actual VA clinics. So we'll, I think, over time, see what that impact is.
Thank you so much. We're going to turn over to Representative Alston. I know that you were at the General Assembly yesterday. I wanted to ask you kind of what the conversation has been about these cuts, and how are rising healthcare costs being mitigated?
Oh, sure. How much time do you have? Not much. Well, first, I'm going to answer both of those questions, but I first want to say thank you. It's great to be here. And I have two very quick sidebars, if you'll indulge me.
Absolutely.
First, I will have been married 10 years next month, so I don't need a wedding venue, but I've long wanted to be a wedding officiant, and no one has hired me yet. So just know that I'm here. If you hear of anybody that needs an officiant, I love a wedding, so just keep that in mind. The second sidebar is a little bit more serious, and I'm sure you hear this a lot, Secretary Kinsley, but I just want to, folks in the room here are engaged and informed, but I just want to say thank you for your leadership and your service. Secretary Kinsley came into that position still kind of in the throes of the pandemic, and then oversaw Medicaid expansion, and then got thrown Hurricane Helene as an enormous public health disaster. And so that's a lot to bear. I know you sign up for that when you take on that role, but just thank you for your leadership. And so in terms of conversations in the General Assembly, well, I think when it comes to Medicaid, I think we also have to pan out just a bit and just frame any conversation about Medicaid or Medicaid cuts in this larger and very frustrating and overly just prolonged battle around the budget. You know, we still don't have a state budget, and there's a lot of political gamesmanship that's being played that has kept us from having a comprehensive fiscal plan that folks in the state deserve. And so with that as the backdrop, just this week on Monday in the Senate and Tuesday in the House, there was this kind of quote unquote clean Medicaid rebase bill and at least some effort to add on to July's mini budget that where HHS came to us or came to the public and to the General Assembly and said, we don't have enough money to cover our bills essentially and won't for this year. And so the General Assembly allocated, I forget, 600 million in the summer. And HHS said, that's about 300 million short. We won't be able to cover the bills for the Medicaid rebase or cover those expenses. And so just this past Tuesday, we'd certainly hoped that we would fully fund the rebase, but unfortunately we didn't do that. You know, it was kind of another stopgap bill that only went part of the way. And I think it was really, really frustrating. It's frustrating just because of the fact of the matter. It's frustrating because really I think everyone wanted this to be fixed. You know, I know Republicans who were frustrated. I certainly know Democrats who were frustrated. And I think this was right there in front of us to help fix this problem and avoid a situation where we're having to face eventual provider cuts. But instead, we're dealing with what in my mind feels like just like a true willful neglect of our duty to do our jobs. And that's going to result in, I think, what you're hearing from my friends here in terms of provider cuts and reduced services and less mental health support and poor health outcomes for folks. And I know in Durham, I have a little bit more, but
Please go ahead. Absolutely.
But in Durham, something that we've been looking at since the Big Beautiful Bill is, my numbers may be off, but something in the range of 20,000, at least 20,000 people minimum, who are extremely vulnerable to having their coverage cut or their services reduced, depending on what happens in Raleigh and in Washington. And, I see it. We get calls from constituents. We had a call, I think, this week from a mother whose son is disabled. She is his caregiver. He requires 24/7 care, and she's preparing for a loss of coverage. And so in order to do that, she has to get another job, which then puts her in the predicament of not having someone at home to care for her son. And that's just one example, but there are folks whose whole lives are going to be disrupted by our unwillingness, frankly, to come to a deal and do our jobs. And so that's what we're seeing kind of day in and day out at the constituent level and certainly just at the kind of the chamber level. In terms of how to mitigate costs, I am no expert in this space. I only know enough to be dangerous. But from what I can see and what I know, I think it's going to fall upon really all of the stakeholders in this space. It's going to call on the whole ecosystem to help try to mitigate whatever the downstream impacts are from federal cuts, to improve access for folks, to support our rural hospitals and help the pipeline of employment, particularly in our rural communities for healthcare jobs. We need to improve transparency for folks. It's really challenging. I have it happen. I'm sure you have too. You can go to two different doctors in the same town for the same thing, which maybe, was curious what you're up to, but, and have, you can be charged two different things and not know about it ahead of time. So I think things like improving transparency, improving access by assisting with our pipeline, supporting our rural hospitals, trying to cultivate a system of care that caters to the whole person, try to create some efficiencies where we can, are potential ways to help mitigate some of those costs.
Thank you so much.
Don't quote me, I don't know what I'm talking about.
The next question we have is, a lot of the times when we talk about Medicaid, I think we talk about the patient, which I think is vastly important. But I think sometimes folks miss the fact that Medicaid covers a lot of the administrative parts of hospitals and keeps a lot of our hospitals open. Secretary Kinsley, do you mind just putting a little bit more insight on that and talking about what these cuts could mean in terms of facility closures in North Carolina?
Sure. Well, first I want to say that my brother's getting married on the 4th, and I am officiating his wedding. But if you would like to do it, I'm happy to trade off. That'd be a good surprise for him. Yeah, exactly.
I have too many jobs I don't get paid for.
Yeah, no joke. So Medicaid, a couple things. One, Medicaid expansion disproportionately helped rural North Carolina. When you look at the total number of people who received insurance coverage through Medicaid expansion, a higher percent of folks living in rural communities have it. That's because, and perhaps unsurprisingly, people were 3 to 4 times as likely to be uninsured in rural communities. Now, again, that's not because they're not working, but it's often because they're working at one of the 44% of small businesses in this country that just can't simply afford to offer health insurance. And they were making a wage that was not enough for them to buy coverage through healthcare.gov. By the way, coverage that's about to get more expensive. And so we saw Medicaid expansion really make a huge impact in those rural communities, which was great news for North Carolina because over the last decade preceding Medicaid expansion, we had about a dozen rural hospitals close. Now, that's not surprising to anyone because when you've got 30 to 40% of the people in your community walking through your front door without a way to pay, how do you stay open? If you're operating any business and 30, 40% of the people come in asking for something they can't pay, what do? Right? First thing you do is you drive up everybody else's prices. Because we have a law and a value in this country where if people are sick and they show up at a hospital, you can't turn them away. And so they're getting the care. And so the first thing hospitals do is they drive up their costs for everybody else who can pay. That's why people came together from a lot of different places, insured and uninsured, to say we have to do Medicaid expansion because we see in states that have it, it controls costs across the board. But now to lose people that are covered, we're going in the wrong direction. Right? We've got more people now coming in the front door without a way to pay, which is going to put those rural hospitals and facilities broadly back at risk. It's why, and unsurprisingly, we have a workforce shortage on healthcare in rural communities because they just can't simply make it work. Medicaid has another program called state-directed payments that gives dollars directly to hospitals to try to ensure that stable infrastructure is available. I think of it like firehouse infrastructure, right? I've never had a house fire, but I'm really glad there's money going to the fire department down the street from my house because I want it to be ready and available for if I need it so it can come. We do the same thing with rural hospitals in this state and hospitals broadly as we give them some Medicaid dollars as a base to keep them operating so they're available when they need to be available because they may not have the same throughput. Those payments are getting cut as well. So that's some ways that Medicaid kind of keeps that infrastructure ready for us.
Thank you so much. Can you talk a little bit to if we know the number of expected closures with Medicaid? Do we have kind of an estimate of what that will look like for our hospitals across the state?
We don't. And, right now, as I said, we've had about a dozen close in the preceding decade. I'm hopeful that there will be no closures. I'm hopeful that we'll figure out clever ways to do things. We do see this rural health transformation program that's coming from the federal government. But frankly, it's a risk. Here's the other thing I would say, and this kind of ties into Representative Alston's point about care. Perhaps the first and most obvious way that we can drive down healthcare costs is by people being healthy. Right? Prevention, ounce of prevention, pound of cure. And we saw that in one of the programs actually that we pioneered in partnership with the General Assembly, which was the North Carolina Healthy Opportunities Pilot. We took Medicaid money that usually would pay for people to go to the doctor when they're sick and instead used it to buy people food boxes, to get support to legal representation, transportation, all the things that we know drive health overall. And in the first 2 years of the program, we saw that people went to the ED less, statistically significant, went to the hospital less, were hospitalized less, and we saved $85 per person per month on the program, net of all the costs. Just to put that in frame of reference, think of that as your insurance premium. If your insurance premium could go down $85 a month after you got all the food and stuff, and that was all included in that, and you're still saving money, it's a big deal. And that's because people were healthier. And so we were driving down the need for expensive chronic care. And that's why that's so frustrating to me about the desire to try to find savings in healthcare costs, because in the end, we will pay for it anyways. We'll pay for it because people will show up in the emergency room because they have nowhere else to go, and after several times there, perhaps they end up experiencing homelessness with costs on society, or they're struggling with mental illness or substance use disorder, which ends up hitting our pockets for all of our communities in a lot of ways.
Absolutely. Thank you so much. Captain Peoples, I'm going to hand it back over to you. So we know that there is a Garner location that opened. Wanted to see if you could provide some insight on how that's been going. And also, we know that we've seen in the headlines that we've heard that new VA clinics are coming at the same time where cuts are happening. So give us some insight on how that works.
Yeah, it's a great question. Math is not mathing on those, but we'll see how it. Yeah, so since the Trump administration's second term has started, there's actually across the country been 17 VA clinics that have opened in some capacity, and Secretary Collins loves to go take the picture in front and say the Trump administration's opened these 17 facilities. We all know that it takes years to build a medical clinic. So specifically for the Garner facility, it's been being built since 2021, and for the community, if it operates as it is planned to, and it should, it's going to be a huge win for veterans in specifically Wake and Johnston County. I live on the edge of Wake County, but in Knightdale, close to Johnston County, and right now, currently, there's 4 VA medical clinics. There's tons of different outpatient clinics or primary care offices across the state, but there's a clinic in Asheville, Salisbury, Durham, and Fayetteville. So Wake and Johnston County have the 2 fastest growing populations of veterans in North Carolina. So currently, veterans that live in those counties have to either drive to Durham or drive to Fayetteville. I am part of the Durham VA clinic here, so drive about my hour drive or so to get there. So they strategically are opening a new clinic in Garner, so those Wake and Johnston County veterans will have a facility much closer. Now, and it's supposed to have primary care, outpatient services, mental health, cardiology. It's supposed to basically act as everything that Durham does, urgent care. And it did open on July 29th to about a 25% capacity, I think, at what it's supposed to operate, which, to be fair, most clinics that open aren't always opening right at 100% capacity. But all they're offering right now are the primary and a few mental health services right now. But one of the big differences I could see in the last few years is like the communication about what's going on. If I'm a veterans advocate, so I'm researching these topics and in the know. But if you're just your average veteran that lives in Wake or Johnston County, they would have no idea unless you drive by the facility that this facility isn't there. There's been no outreach or communication to veterans that, hey, this new clinic's opening in your area. I think because they know they're opening at such a low capacity. There's one that just opened in Chesapeake, Virginia, that got some national headlines because it opened at such a low rate of service. And right now, veterans that live in the area, we're getting no details about when all the other services are going to be offered. It could be we just keep later this year, early next year, and I think that ties back to what I was saying. The recruitment problem right now with doctors and nurses is holding back being able to operate at these facilities at full capacity, which is a travesty because really, like I said, that's going to save a lot of travel time, and especially if there's an urgent care right there in the area. Because with the Doge cuts, they definitely communicated it as it's not going to be your frontline, services that are going to be cut, the doctors, the nurses, the psychologists. It's going to be the support staff. And to that, I'd say, in the military, I was a support staff. I was someone, and my job was a logistics officer, so we would, serve the frontline combat units, get their food, their water, their ammo. They were the most important part of the operation to say, but as soon as you start taking back the support staff, the whole operation starts to crumble. So the doctors and nurses I've talked to, specific example, there was one person I talked to at the Durham VA clinic that was part of the janitorial staff that would come in after an operation or a service, and they would clean the whole operating room. And now if that person got cut, then the nurse is having to work double, or they're having to, do what the janitorial staff was doing. There's starting to be a shortage in procurement specialists, people that are ordering the prosthetics for amputees, or people that are ordering medical supplies for the pharmacy. So with that, you're going to start to see a lot more burnout from the people that are remain, because they're having to basically work 2 or 3 different jobs that if we were fully staffed, they wouldn't have to be doing. So, you know, the communication staff is one, and then also the claims administrators is another area that's going to be a big impact. Where right now, you know, if you think in the military, a lot of people like to stay in for 20 years because of all the benefits you get if you can retire and stay in for those 20 years. So if you think about the type of veteran that's now leaving the military, they joined in, let's say, 2005, 2004, you know, right in the heart of when the conflict started, that have been probably to Iraq or Afghanistan 4, 5, 6 times, and they're going to need a lot of care when they get out. So if the claims process is slower or a lot more convoluted, it's going to be a lot tougher for them to get the care that they are going to need right now. So, yeah, that's a lot of the effects we're seeing from it. And my organization, we're trying to, you know, continually work with the people at the Garner VA. The people that are actually there are doing a great job. They're the ones that have been hired, and they're working their tails off. But it's the, you know, the greater leadership that's failing in getting the message out to what's available to the veterans.
Absolutely. One of the things that you mentioned was messaging and how important messaging is. And so, a question that I want to ask all three of you of with all of these changes, we know that there's an education gap in North Carolina. Many of us in this room know what's going on when it comes to healthcare or politics, even in some form. We know that's not the case for everyone in North Carolina. So, how important is messaging with the changes to Medicaid and the VA, and what are the expectations for appropriate communications from the Department of Health and Human Services, from local organizations, and from members of the General Assembly?
Oh man, I think messaging is always important, and I think education is always important. And you know, it's one of those things. I think, particularly with something like Medicaid, you know, where frankly a lot of us have the luxury to, unless you kind of work in these spaces, you don't have to engage with the policies or the programmings or the services that fall under Medicaid. And so it's not a part of our everyday lives. And unfortunately, I think a lot of the kind of converging crises that we're seeing flow down from, you know, I won't call it the big, beautiful, whatever. Yeah, HR1, that, you know, all the downstream impacts of that are going to have such extreme impacts on cost of living for all of us, no matter your income level, your education level, no matter where you live. I think is bringing all of this home. And so I think we have this, again, unfortunately, this moment where folks will be captive, or not captive, but like receptive, I think, to education around how their neighbors are being impacted, because I think it's just going to be 10 times more relatable. So I think, you know, we just have to be very proactive and aggressive and clear in our constituent services. I think it's just speaking as a legislator. I mean, not like really so much of our work day to day is constituent work. It's not really messaging or, you know, kind of the flashy political things. It's really just helping people solve individual problems. And so it's using those moments to educate individual people, being consistent about that, always closing the loop with people, making sure they have the right information about services, communicating with our agencies, again, to make sure we're communicating the right information to the people here on the ground. So it's great constituent work, it's great relationships with our state agencies, and just a commitment to kind of using this moment for good. I don't know how else to put it. I don't know, things are bad.
Yes, they are. Yeah, from the VA's perspective, first just, you know, I think messaging to get more people into the system, you know, and obviously more doctors and nurses to provide for these people. But the messaging first needs to be that, you know, as a veteran, it doesn't matter what your political affiliation is, you know, if you served, you're entitled and you deserve this care. So it should be a nonpartisan issue about, you know, VA healthcare should be a nonpartisan issue. And a lot of people I speak to, it is. I mean, I have veteran friends on all sides of the aisle. So, you know, it should be, hey, let's make this system the best we can for all veterans, no matter what their background is. But really, there was, just going back to kind of communications, it was during the Biden administration, the PACT Act, it was a triumph of communication within the VA when they released the PACT Act, because, you know, it was so many more veterans that were eligible for care due to, when they served in Iraq or Afghanistan or Vietnam and being exposed to these burn pits. So, I would go, when I first was in the VA, I would go, a year without receiving an email or anything from the VA. I would have my annual checkup or whatever, but when the PACT Act was passed, I was getting constant emails and calls. There was a priority put on trying to reach every single veteran in this country to say, you might be eligible for this service. Come to the VA, get a screening for toxic exposure. If you have a symptom that might be covered by this, then we'll help you in submitting a claim. And within just a few years, there were I think it was about 5.5 million veterans got a toxic exposure screening, and about 2.5 million put in new claims. And like I said, over 1 million have entered the system and are receiving care that they weren't prior to the PACT Act being. So having just more people on the outreach and communication team, because the VA has had a stigma for years about, the care is not going to be good. Let me just go to try and find a private care doctor or do something else. The VA, but we've shown over the last few years, if you put the investment in and you put high quality people in, at the Durham Clinic, we've got doctors from Duke and UNC Medical, just people that want to serve and help these veterans, just top-notch doctors across the country. The people are going to come and want to use this service, and it's going to be, best for the veteran community as a whole.
Thank you.
For a moment there, I was worried you were going to opine on which doctors are better, from UNC or Duke. I thought this was going to devolve rapidly. So, I think the two things I will add to this is that, what we saw in our rollout of Medicaid expansion, here is an opportunity that was all of a sudden available to folks who had attempted to get insurance coverage through Medicaid for a long time and had been turned down over and over and over and over and over again. So there's a lot of myth and a lot of confusion, but yet we were able to get, over 600,000 people on in just a year. And I think the key success to that, what really drove that, was not just what the message is, but who the messenger is, right? Like, I am not the right messenger in many communities and in many spaces. And so making sure you're partnering with the right folks to be the messenger, to carry that information. And it's really, look, your neighbors, your friends, your family members, they trust you way more than they trust me. They should, I hope so. If they don't, you have a problem. But, the conversations that you're having to carry the information about what's unfolding is so powerful. And so I think, as you leave this space, I think remembering, that the First Amendment to the Constitution is freedom of speech. So there you go.
Thank you so much. So I feel like one of the groups of people that we often leave out of this conversation is children in foster care. Representative Alston, I know you worked on a child care reform bill. Can you tell us a little bit about the bill? And can you help us understand how and if the state underfunding the rebase affects kids in the foster care system?
Sure, I appreciate any opportunity to talk about House Bill 612, which I was really, really humbled and fortunate to be a part of. It was really a huge coalition of people who kind of brought that bill to bear. It's gone through several, we were talking about it earlier, it's gone through many iterations in the past few years. I was certainly not the primary architect of it, but I was really thrilled to be a part of the effort this year to get it passed. And so really it's a suite, kind of a large bill, a suite of reforms to the child welfare system. And its goal is really just to move us a step towards a more efficient, more predictable, just a stronger child welfare system that truly, prioritizes safety and permanency for kids who encounter the system. So there's a lot in there we can run through, but it's a really, I think it's a really strong consensus bill. In terms of the, potential impacts of, kind of potential Medicaid cuts. So, whatever's happening with federal or state funding for Medicaid doesn't directly impact this House Bill 612 or its implementation. But any impacts to families who rely on Medicaid coverage or SNAP benefits, any impacts to that population kind of will impact children who encounter the foster care system. I think that's inevitable. So I'll just mention maybe a couple things. I think perhaps most directly, to the extent there is a tether, there's and help me if I get this wrong, I think it's the Children and Family Specialty Plan, which is we're moving in the state from kind of a regional healthcare model for kids in foster care to a single statewide plan. And that's set to roll out, I think, at the end of this year. And I think the risk is with that plan, or really a whole array of services, if Medicaid's cut, if the provider cuts happen the way that they're projected to, that could impact just the population that is served by this plan. I think those impacts will be real and will be felt, which is really, it's unfortunate. I think this is a huge kind of really kind of monumental shift for the state, and to provide healthcare consistency for kids in the foster care system. So to have to worry about it being vulnerable in any way is a tragedy in and of itself. And I'd say, again, just kind of panning out a bit, again, the well-being of a caregiver is, again, it's going to impact the well-being of a kid in the system, or a kid who's in their care. I think particularly with SNAP benefits, which is something we've talked with our county officials quite a bit about, the concern about SNAP benefit cuts. I think 1 in 6 kids, I may be wrong on this, I think 1 in 6 kids in the state rely on SNAP benefits. And, cuts to that system for a family, if they move from having that coverage and those benefits to being food insecure, it's gonna necessarily make them vulnerable for worse health outcomes and worse stability kind of in their day-to-day lives. So, should everything unfold the way we expect it to, it could be really tragic for kids in the system and their families.
Absolutely. Speaking of kids, it's back to school time. It is flu season. I want to talk a bit about the flu vaccine and the COVID-19 vaccine rollout. Captain Peoples, could you tell us a little bit about how the rollout of this year's vaccines has compared to previous years at the VA?
I can. I was just there last week getting my flu shot, and it was a really different. When you compare it to last year's, is the difference in 1 year is kind of like a example of how elections matter. Last year, as soon as Labor Day hit, every VA clinic in North Carolina basically had a walk-in for any veteran Monday through Friday, 7 to 5. Come in, get your flu, COVID shot, in and out, easy peasy. And this year, going back to lack of communication, I couldn't really figure out when my clinic was gonna have it yet, or if they were available. So I decided to just do a walk-in, and they are not available at the VA clinics, at least in this general vicinity yet. They are working on getting them soon. But going back to the community care, I was able to go to a Walgreens and get the flu shot. But as of right now, they said the COVID shot wouldn't be covered by my VA insurance. So, someone like myself who, anyone who most people who join the military, you get very used to, you have to get every vaccine under the sun to join the military. I was in when then the anthrax vaccine was developed, and I actually had to get it, or I got it 3 times because they kept losing my medical records and say you didn't have it. So I think I'm really protected from anthrax if it ever comes. But no, it's just a night and day shift of one administration to the next, where they're clearly not prioritizing the COVID vaccine. That's not. I'm just speaking for the veteran community. I know that's across all communities, and that goes back to earlier in the year. If you were following the news, if you remember when COVID happened, any veteran or any active duty service member at the time that refused the COVID vaccine was separated from the military because there was COVID running rampant through military units because you work in such close quarters. So if you weren't willing to get the vaccine, then that was federal policy. You'd be separated. Definitely agreed with that policy. And then all those soldiers, if they 4 years later wanted to be reinstated into the military in the new Trump administration, they could get their job and back pay for being out of the military for 4 years for refusing the shot. And that was the same week that they banned transgender services from serving going forward. So definitely, you can tell their priorities there. So definitely why elections matter. And I'm hoping that in the next month we'll be able to, veterans across North Carolina should be able to get the COVID and flu vaccine, but it has been a scrambled mess so far, I would say.
Thank you so much. I was at the doctor last week and they did not have their COVID vaccines yet. So I'm seeing those, and I think we're seeing some of the holdup with vaccines across the state in general. Next question I have is for Secretary Kinsley. So, going back to work requirements, which I know you mentioned at the beginning of this panel, we know that we have waiver programs with some of our most medically fragile North Carolinians, some of which aren't able to work due to their disabilities or medical communications. How do work requirements play into those waiver programs now?
So by and large, work requirements will only impact the folks that are on expanded Medicaid. So that roughly 675,000 people. But indirectly, it will impact, everyone that's on Medicaid's efforts to get onto Medicaid or to navigate it, because the same eligibility workers in each county, we do eligibility at the county level in North Carolina, will be essentially having to do twice as much work for 675,000 people now. Instead of determining their eligibility once a year, they're going to do it twice a year. They're going to have to help navigate people through all of the paperwork requirements, and so there will be lots of changes. And I don't know if you've talked to our county partners, they will tell you that it's already a struggle to staff in their county DSS offices and to have these eligibility workers supported. And so what we worry about is just the general amount of effort and time that everybody will experience moving through the process.
And could you provide a little bit more clarity on why we moved from that year process to that 6 month?
So that's a requirement in HR 1. So the requirement of HR 1 is to move to once every 6 months, so twice a year.
Thank you. Okay, we're down to our last question, y'all. So it is a very general question, and that is by intent, and a very loaded question, also by intent. So the question is, how do we get back to a middle ground, and where can we work with people of different backgrounds and experiences to move forward as a state? Who wants to start?
I have to start. Not it. You're catching me after a hard week,
Yes.
Hannah. My answer might be a touch cynical. I mean, I don't know if it's a matter of getting back to a middle ground. I think it's a matter of finding it. Perhaps we found it with expansion, and maybe there are these bright spots, and we've had some bipartisan legislation. I don't know the answer to that. I think we're all searching for it. Yeah. I hope it isn't the case that, again, I feel, and I'm sure you do too, that, I feel like cost of living is going to reach like a really, really tough breaking point. I think feelings around safety and public safety are also reaching this really, really tense moment. And I just hope it isn't the case that things have to get so bad for a critical mass of folks that we are vulnerable enough to decide to want to compromise and decide to want to work together, and that our common interest isn't just crisis. I hope that's not the case. I want to hope that traditional tools of coalition building, of building relationships and trust and working together and trying to serve the most people with the most efficient policy ideas, I hope those things can predominate the conversations and the work that we do in the General Assembly, but we'll see. That wasn't too cynical, was it?
No.
That was good. Yeah, I would say, I would look to at least when I was in what the military model used to be. I'm afraid under the current administration they're going away from it. But when I was in the military, it's the most diverse workforce maybe in the country or the world. I was lucky enough in my unit to serve with people from Ghana, Kenya, the Philippines, Venezuela, Mexico, people that weren't naturalized citizens yet, people from the mountains of West Virginia and Montana and Detroit and Atlanta, and just people. So that's my pitch for anyone who wants to join the military. That's you're going to work and get to be around people that you never would have without coming together for this mission of protecting the country. And I had I served at the beginning of the Bush administration, and then mainly during the Obama administration. But I know I served with people that were very right or very left, and we didn't talk politics. We all had our mission. We all came together. to do what we needed to do, and it just seems like we're losing that. And it's hard to do that right now with the atmosphere, the media atmosphere we have, the social media atmosphere. But to see the other side as your fellow citizen and your neighbor, and then hopefully it's someone that you can work with to, we're gonna have disagreements on policy, but to see them not as your enemy, but as just your, political opponent, but then as your neighbor. And I just remember I didn't join the military because what happened on 9/11. I remember I was inspired to join the military because I remember what happened on September 12th, just seeing our country come together so much. And I'm terrified if we ever had something like 9/11 nowadays. What would that look like in our country? I just remember politics was not a thing. We all came together during that time. And I've got a 5 and an 8-year-old, and definitely want them to grow up in a country where in our times of crisis that we come together. So part of the organization I work for Veterans for Responsible Leadership, we try to help elect veterans into office, but criteria is more about integrity and moral character of the person versus just their general policy views first. So when you're looking to leaders, look for their integrity first before what their specific policy views on anything else, and hopefully that they can lead us out of this mess that we're currently in.
I'm an eternal optimist, and I'm a half glass full person, and all the things. So I just kind of I own that. And I was recently I did a trip to Taiwan as part of a delegation of state health secretaries that went to meet with the Taiwanese government, and in turn they came here to North Carolina just a few months ago, and I was meeting with them, and they pointed out to me that in the Mandarin characters that represent crisis and turning point, they share a similar Mandarin character, which is the word opportunity, and that it is in both. And for me, this spoke such volumes. I have frequently used the word crisis-opportunity because I have found that in the midst of crisis, you can usually chart a path to figure out how to get something done, either because everybody is like not paying attention, or because you really maybe intensify the messaging in a way that really gets people's attention. So I think that we are in the midst of great change, and I think that offers a crisis-opportunity. I think it offers clarity about the fact that we will see the biggest changes in people's healthcare experiences that they've had over the next several years, and we know exactly why. And we can point to that and who needs to own that. And two, that we can try to figure out a way to offer an alternative vision. I think this is the challenge for all of us, which is to remind ourselves that we actually have a lot more in common than different. That we're all really frustrated with the cost of living. We're all really frustrated with the cost of housing. That healthcare is stressful, and the risk of navigating, like as Representative Alston was saying, like you walk into the doctor, you have no idea what's going to happen. At the most traumatic experience or moment in your life, maybe getting a diagnosis, you're in an emergent situation and having care in an ED, you have weight on top of you of navigating the bills and all the trauma. That is not something that only Democrats experience. That is not something that only Republicans experience, right? That often I believe we can agree on the what needs to be different. The challenge is often the how. How do we get there? And I think the only way we do that is by having conversation. You have got to reach across difference, whether it's your neighbors or other folks, your family members. I don't believe in polite Thanksgivings. I don't believe in polite Christmas dinners. Like, you've got to talk to people about things you disagree with. Now, and you do it right. And we've gotten to a place where we used to think that the other side was wrong, but not evil. We've got to get back to wrong. We can disagree on the policy of the substance, but just because someone holds them to, I'm a gay man. I have worked closely with people who do not believe in my right to exist barely, and let alone get married. But that didn't diminish my desire. I mean, I understood that they were also a product of their upbringing. They were a child of the churches that they went to, the experiences they had, and I shouldn't diminish the depth of their belief, but I would try to reach beyond my difference to try to understand. And I think if we could understand more with each other together, that's how we're going to get to the future.
Very well said. I will say, bringing it back to Carolina Forward and Influence NC, that is one of the things we're trying to do with Influence NC, is get back to that middle ground and close that education gap, because I would put money on that everyone in this room knows who represents them in terms of their district. When they go to vote, they know who their state representatives are. That is not the case for everyone across the state. And I think some folks are not even opting into the conversation of politics because of what we're seeing in the media. I feel like everyone up here gets it more than everybody. It's depressing and it's overwhelming, and I'm sure for everyone sitting here as well, that would be the same case. And for Influence NC, we're trying to make it a little bit more fun and lighthearted because while there's a lot we can change in North Carolina, there's a lot of great things about this state. And there's a lot of great things happening locally in this state that I want to make sure we're highlighting on a lot more, because then it makes the big scary things feel a little bit less big and scary. So thank you to everyone on this panel. Please give them a round of applause. And thank y'all for joining us. Again, we know that on a Thursday night, there's a lot of places you could be and you chose to be here. So thank you. We did record this tonight. We will have it up next week for everyone. Please share it. And we do have a lot of food and drinks still left, so please go mix and mingle, eat, and get home safely.